So we're doing our own introduction, and now I can get to ad lib about what I wish I'd done with my life. Um, but I was an Army Nurse Corps officer, big surprise, and had, a variety of, just like everybody in this room, a variety of assignments across the United States and in Europe. I was very fortunate to get picked up for both my master's and my PhD through what was then long-term education and training, and then came back to BAMC and retired as the chief of clinical investigation out of BAMC. Was the first nurse to hold that position. It generally had been a medical corps officer position, but I put in an application and was fortunate enough to be selected. I retired in 2008 and then joined the faculty at the University of Texas Health Science Center. And what I'm going to do today is overview some of the research that we've been conducting over the last 10 years. This is your tax dollars at work, as well as the work of Army Nurse Corps officers and a number of retired military members. So this is absolutely perfect timing. We've just had some of our major publications come out, and it was great fun to take the opportunity to summarize some of this research. Now, objectives, of course. So this is for CE, remember, so, you've got to do this. So what I'd like to do is, kind of overview the diagnosis, risk factors, and differential diagnosis for post-traumatic stress disorder, or PTSD. And then overview the findings from the Strong Star studies conducted treating combat-related PTSD, describe some of the nursing interventions in the diagnosis and treatment, and then talk about the enhancements and treatments that we think need to be tested out to actually improve those treatments. Now, any of you that know me could maybe be thinking out there like, she's a complete imposter. She was never a psych nurse. And Kathy Gaylord is in the audience, so she can call me out for anything that I say incorrect. When Alan Peterson, my boss, first recruited me to the position, I knew he was doing psychological research, and I'm like, you do know I'm a below-the-neck nurse. I have been a cancer nurse all these years. And he said, no, I've got plenty enough psychologists and psychiatrists to work with. I need a partner who has conducted research in the military, who understands the military system and can help us navigate regulatory stuff, get these big studies up and running, conducted to the highest standards, and then the findings published. So, as I'm sure you'll guess over the course of this presentation, I've completely drunk their Kool-Aid. I am a huge proponent of psychological health care, behavioral health care. It's been a really nice way to retire, to continue working with active duty service members and their families as we're doing these. So it's been a nice soft landing. But I'm relatively new, just 10 years to this, so I've tried to be a quick study. So I think I knew kind of sort of what PTSD was when I first joined this group. People get stressed in combat and they come back and they're different. But there are diagnostic criteria for it, and we have worked really hard to hold ourselves to these standards, make appropriate diagnoses. And I'm going to show you some data about that. But PTSD results from exposure to an extreme traumatic event, and you can see examples of that there, including military combat. And the symptoms include distressing memories, dreams, flashbacks, avoidance of the trauma reminders, negative changes in thought processes and mood, and heightened arousal, irritability, easy startled, difficult concentrating, sleep disturbance. A lot of these are very generic. Many of us have these type of symptoms that occur just as a matter of life. So that's why the diagnosis is so important to make. It has to be a constellation of symptoms around a specific or a group of specific traumatic, life-threatening events people were exposed to. PTSD affects about 7% of Americans, more women than men, but the percentage is twice as high in military service members, probably around 14-15%, somewhere in there. The important thing to remember about this number, that better than 85% of service members deploy into really dangerous situations, exposed to horrific trauma, and they come back and they are good. There are 15% that are really profoundly affected by what they've experienced. And we have tools to help them make sense of that because it's nonsensical. It's not something that you easily can get figured out, but we're looking to test those tools. I find this so interesting, the rate of PTSD by trauma. So the trauma are the clay-colored white bars there. And if you look at disaster, like what has just happened, Florida, Americans will experience a disaster in their life, go through a hurricane, go through a fire, whatever that is. But a very small number of people will develop PTSD out of that. I don't know, what is that, maybe 3% or something like that. A similar number will have a motor vehicle accident, and a few more will develop PTSD from a life-threatening accident, assault, molestation, and then you get to combat, and a relatively few number of people will experience combat, and yet many more will experience symptoms of PTSD. And then look at rate. Very, very small number of people will be sexually assaulted, but the rate of PTSD is huge. And if you look at men in this group, it's astronomical. If a man has been sexually assaulted, the chances of him getting PTSD are really high just because of the profound influence that has on someone. So, you know, we can begin to build profiles. Who might be at risk? Who do we need to think about, target? The gold standard for PTSD diagnosis is a clinical interview with a trained professional, psychologist, psychiatrist, clinical nurse specialist, a trained evaluator. And it's right now with the DSM-5, it's called the CAPS-5. There's also self-report checklists, and I'm sure the active duty people, we could have a really interesting discussion. People get thrown the PTSD checklist, the PCL, again and again and again and again. And they know what to answer to not get tagged or snagged or delayed. So, you know, there are some issues around self-report, but it is a measure we have. Generally, the screening questions are, you know, in the last month having nightmares, tried hard not to think about the events, been constantly on guard, felt numb, guilty, you know, unable to stop blaming yourself. Avoidance of thinking about these things is a big part of PTSD, and that's very challenging because you may be experiencing symptoms, but if you push it all down and you don't need treatment, then you don't avail yourselves of treatment. So when people are finally having so many of these symptoms that they present for care, that's pretty amazing in and of itself. They are really starting to feel bad. Things are starting to fall apart. There's a lot of folks walking out there with these symptoms that probably could get diagnosed with PTSD, but avoidance is alive and well, and you can, you know, put it to the side. You can, you know, do bad health behaviors just to try to suppress those. So how to try and get around that. There are 6 criteria for PTSD, first one being exposure to traumatic event. With the DSM-5, there's 4 sets of symptom criteria, and the duration needs to be at least a month by diagnostic criteria, just to put that out there. But not everybody has PTSD. I was absolutely amazed. We opened our first 2 big studies up at Fort Hood. The first 300 treatment-seeking service members. So they were bad enough to want to come in and get treatment. And when we administered the diagnostic criteria, only 80% of them met the criteria for PTSD. It wasn't that those people weren't having symptoms. They absolutely were having symptoms. They showed up for care wanting help, but they didn't meet the diagnostic criteria. So I think we need to think about that, work with that. There's a lot of, maybe you want a disability, maybe you don't want to be treated, or maybe, you know, you want to be able to retire, get a VA disability out of that. There's so many politics involved in all that. I think our approach has been meet the person where they're at. And if you want to have care, maybe we don't do a PTSD study, but let's apply some of the tools we have to see what we can do about it. And since the DSM-5 criteria there's even more people that have screened out, and we're still trying to get that figured out. We think it has to do with the avoidance questionnaire, and if you're on active duty, you don't get to avoid going to work. Guess what? You know, you're going to be there, or somebody's knocking on your door, ringing your phone, or bringing you up on charges. So if avoidance isn't an option for you, then, all of a sudden you're not meeting criteria when you still have other things going on. So, anyway, we're trying to sort that out, help figure it out, help inform the field. There's been a lot of discussion around, do we call it post-traumatic stress disorder, post-traumatic stress, or just PTSD fine? There's been a lot of opposition to the term disorder by very senior military leaders, and suggestions for calling it other things. We kind of think that perhaps the most important point is that civilian research has shown that PTSD can be treated, and military members, deserve that treatment for the symptoms they're having, and let's get after it, and however it is to that. This is another set of data we had from almost 1,500 soldiers that were we evaluated as they went into trauma. They were a year-long deployment in Iraq. It was 4 different combat brigade units based up at Fort Hood. And then we interviewed them again. This was with the diagnostic interview, not just self-report, coming back out of theater. And half of them, well, 52%, had no post-traumatic stress, no evidence of it at all. But a quarter of them had what you would define as post-traumatic stress, and another quarter had post-traumatic stress disorder. So, it's out there. People are experiencing symptoms. So how is combat-related PTSD treated in 2014? The Institute of Medicine came up with their report, and the first-line therapies of prolonged exposure, cognitive processing therapy, EMDR, eye movement desensitization, and reprocessing stress inoculation are all recommended, felt like they had enough evidence for that. There's also 2 FDA-approved medications, both antidepressants, that were approved at different times. Generally only about 50% of people will respond to medications. Our belief is that that's not going to affect the long-term cures that we're hoping to achieve. And it may well be that people need to have medications to handle extreme symptoms, take the edge off, have people open to coming into the behavioral therapies, but we don't think that that's the entire answer. But to talk to Strong Star, I need to take you back to 2008. And in 2008, this was the IOM report on how PTSD was to be treated. And at that time, the committee concluded that there was scientific evidence for the efficacy of the exposure therapies, but not for EMDR, cognitive restructuring, skills, and that there was inadequate information to determine the efficacy of treatment with medications. Now, I saw Kathy Dolter's name on the agenda. I'm not sure if she's here yet or not, but I have to give Kathy a shout out. She helped put together the panels that developed the clinical practice guidelines. These are VA, DOD clinical practice guidelines, and then put them out to the very high quality documents, and then put them out to the field. But it was in this environment in 2008 that the 2007 Defense Appropriation to support PTSD put $900 million towards the care of PTSD and traumatic brain injury. It was a bunch of money for clinical services and $300 million for research. And the call was for 3 different consortia. One was a Traumatic Brain Injury, TBI Consortium, and that was the University of Texas at Houston got that award. There was an award for a clinical coordination center, and that went to San Diego. And they did a little work with Tacoma, with Madigan. But generally, both of those focused on civilian trauma, wasn't really focused on military trauma or more basic science work. And then the PTSD Consortium went to the University of Texas Health Science Center right here in San Antonio, and under the leadership of Alan Peterson, who's a retired Air Force psychologist. And if you've never had a chance to meet Alan or work with him or hear him speak, I mean, you really need to do that. He is an amazing scientist, clinician, supervisor, leader, has really shaped Strong Star into what we've been able to do. So it's been very fun. And under Alan's leadership, what he did when he was training director at Wilford Hall is that he would bring in experts from around the country on whatever the condition was and have them do grand rounds for the interns and the residents. And then if it was a topic of interest for the military, he would approach them about partnering. And let me help you write an application. Let's apply for funding. You'll be the principal investigator, I'll be your site investigator, and let's test these interventions in an active duty population. And he was very involved in things like smoking cessation, weight control, clinical health psychology type issues. So when he went to put together Strong Star, he used many of the same approaches. The unanswered questions at the time were, how effective are treatments for combat-related PTSD in active duty military? We know what they do for civilians, but there had been some studies in veterans many years after their combat experience, but we really didn't know, would these treatments even work in active duty populations recently returned from deployment? What percentage of patients can be treated to the point of remission, recovery, or loss of diagnosis? In the civilian literature, about 80% can be treated to remission of their condition, and then there was another study that 80% of those people will stay in remission up to 5 or more than 5 years after their diagnosis. So this is a treatable condition. Many times you feel like, oh, I've got PTSD, I'll never get rid of PTSD, it's like this 5 pounds or 10 pounds that always hangs on me. That's not what the civilian literature would support. We didn't know if cognitive processing therapy, a very common treatment for PTSD, could be delivered in groups. It was designed to be delivered in groups, but they never could test it in a group setting, never had enough concentration of people to do a randomized controlled trial. We had that opportunity. Prolonged exposure, which I'll talk about a little bit more, some more of the details of it. We didn't know if it could be delivered as a daily dose. Typically it's given once or twice a week over 8 to 10 weeks. Hey, military people are busy. You know, they can't always come back in once a week, twice a week, and military providers are really booked. You know, right now they're lucky if they can see people once a month. What if you had cancer and, you know, you're supposed to have chemotherapy and they say, you know, we're really, really busy. You know, you're supposed to have chemo every 2 weeks, but we're going to bring you in every 2 months, 3 months. You know, you'd never stand for that. The goal is to give full dose of care on time. So we wanted to know if we could give prolonged exposure every day. Let's get full dose in a compressed time. Can we get the same results from that? And then what about primary care? A lot of people won't come into behavioral health. There's stigma, you know, I'm not crazy, I'm not going to let those crazy people see me, but they'll go talk to their primary care provider. So is there an opportunity for treatment in primary care? So these were the questions that Alan got us organized to originally think about answering. The original consortium included 14 projects. We were told by the Department of Defense right up front, this is not a gravy train, it's not going to go on forever, you better keep writing applications because we're not sure you're going to get funded again. So we went on and we wrote an additional 27, what we call affiliated projects, and then the Consortium to Alleviate PTSD was funded in 2013, and that's another 11 projects. So this has been a boatload of research that's been done across the country, but primarily here in South Texas at Wilford Hall, Brooke Army Medical Center, and up at Fort Hood. So the demographics of the service members that are seeking treatment, and this is our Fort Hood data, and this will look very common to you. They're about 33 years old. It's primarily men. About half are Caucasian, which means the other half report being of minority ethnicity. 70% are married or partnered, almost all were Army, and then mid-level NCOs, E4s to E6s. Of course, they're the people that deploy repeatedly, get exposed to this trauma. About 10 years time in service, and half had deployed 3 or more times. And these are Army deployments, of course, so they're the year-long deployments going on. So this was the group, I mean, I think we got the target audience. These are the people that, you know, have been exposed, are suffering with the PTSD. Now, the 2 treatments that we tested were cognitive processing therapy and prolonged exposure. And the differences between them, cognitive processing therapy, that was the one that was developed to be delivered in groups. and the participant or the patient writes or reads accounts of the trauma and then challenges the trauma-related cognitions. You know how many people will go into a restaurant and they're sitting in the corner, they're constantly surveying the scene, they're always on alert, they don't go into Walmart because Walmart is a really dangerous place, they don't go out with their families, all of a sudden the spouse has to do all the childcare, all the travel, all the shopping. You know, those are beliefs that maybe kept them alive in theater, but they haven't been able to transition then back to stateside and fairly appraise the environment so you can re-engage with your life. So what cognitive processing therapy does is try to challenge those trauma-related cognitions and practice not doing surveillance all the time and to re-engage with family and friends, with work. Now, prolonged exposure, again, is called an exposure therapy, but with that, the patient goes over the events of the trauma that occurred to them in exquisite detail. You usually make a tape with a therapist, and then you process that, and then every time you come back to see your therapist, you will make a new tape. And it is amazing how people remember different things. Like initially, all you can remember is that you were in the convoy, you were 10 vehicles back, and your NCO got blown up in the first convoy, and you didn't get there fast enough. So it's all your fault. If you had just been there, you could have saved him or her. But by way of thinking through it some more, well, 10 vehicles, well, how far was 10 vehicles? Well, it was probably a quarter of a mile. Okay, so then the bomb goes up. How could you physically have gotten up there to, well, I couldn't. And what would you have done with the people that were, no, I had to take care of them. You know, just trying to appreciate new nuances for these. I'm not going to tell you the one about the nursing ones because I can cry every time I think about some of the events that nurses have been exposed to and that they don't appreciate the good work that they've done until they can kind of work through that with a therapist. So that's the idea of prolonged exposure. Prolonged exposure does create a lot of emotional feelings as you're going through this, a lot of distress. You know, definitely crying, all this idea is, you know, the more times you go through it, the easier it gets, a new understanding. We've all had those experiences. Many times you just need to talk about it, get it out, make sense of it. But you know, a lot of emotion arises from that. So here's some of the findings from the studies. This is like the Cliff Note version of what we found. All of these tables are in the published literature in very nice journals. This is the one that compared cognitive processing therapy in a group setting to present-centered therapy. Unlike cognitive processing therapy where you're working on the trauma cognitions, present-centered therapy, you meet with a therapist, and it's kind of problem solving. What's bugging you today? You know, is it the kids? Is it school? Is it, you know, whatever. You know, you just talk about what is the event as of today, and there's no specific trauma work that goes on. Patients really like it, and providers really like it. It's generally easy to give because you bring people into your office and you chit-chat with them. You know, yeah, you might challenge them a little bit, but, you know, you're not really, you know, getting at the raw spots there. But, you know, we wanted to be sure that cognitive processing therapy in a group setting was at least as good as present-centered therapy, and it was. You can see the lines are just about parallel. It's the percent of participants improving on the self-report checklist. Actually, those lines look pretty similar through treatment. It's not until the 6 and 12-month follow-ups that they start to diverge a little bit. And we think that's because if you go through cognitive processing therapy, you have those tools that then you can apply in the future. If you do the present-centered therapy, when new stressors come around, you might not still have the same tools to do it. So that was good. Okay, we can give cognitive processing therapy in a group effectively. So is it better if we give it as an individual, one-to-one, or is it better to give it as a group? Anybody that have tried to get an appointment in behavioral health knows that it's really difficult. It would be really efficient to see a lot of patients in a group setting, the provider to patient mix. You know, you could put a lot more people through. So we wanted to test it and see what goes on. Well, the red line is the individual therapy, and whereas people in group got significantly better, over time, there was more people in the individual setting that got better. So what we're kind of taking out of this is that there's still demands for care. So maybe everybody goes into a group to begin with. A certain percentage of those people will get treated to remission and are good to go, but a certain group of them need additional follow-on care. So maybe they could go on into individual therapy. So trying to do a little triage here, you know, like the one size does not fit all. That's kind of where we're thinking about this. And then this is the prolonged exposure therapy. Can it be delivered daily? Or will it be too overwhelming for service members? They couldn't possibly go through all this emotional trauma day after day after day. Yeah, guess what? They can. You know, this does not, you know, service members do not get scared. They know how to handle this stuff. So we had exactly the same response if we delivered prolonged exposure once or twice a week for 8 weeks, or if we gave it every day for 2 weeks and got her done. And then this is our primary care study. So putting behavioral care providers into primary care. This was a mere 5 sessions. Typically PTSD treatment is 10 to 12 sessions. This was only 5 sessions, and it's the flat one, this part right here, the dotted line, that was a waitlist control group. You know, didn't want to randomize people to no treatment. So people stayed pretty much the same during their wait list, but then had the decrease in symptoms just as the group who started treatment right away and then ended up in the same place. So this was pretty cool. A lot of senior ranking people, senior officers, senior NCOs, didn't want to go into that nasty behavioral medicine clinic, but they would go into the primary care clinic because, hey, a lot of people go into primary care. It was only 5 sessions, 5 30-minute sessions, you know, pretty efficient care. So we really feel that Strong Star and the studies conducted under the Strong Star Consortium has set the benchmark for the treatment of combat-related PTSD. Now, we're not happy with that first number. You know, we only got between 40 to 50% of people treated to the point of remission. And remember I said in the civilian trauma, better than 80% of people going through evidence-based therapy will have a cure, be remitted from their diagnosis. We didn't do that well with combat-related PTSD. And, you know, we think that there's nuances, there's differences that need to be addressed, and that's what we're trying to take on next. But at least let's figure out if any of the civilian therapies work. Let's not just throw a therapy at a problem without knowing that it's effective. Yes, it is effective, but now how can we do better? We had a 10 to 12 point decrease in PTSD symptoms, which is a clinically significant change. Maybe not everybody went to the point of remission, but definitely had a clinically significant decrease in symptoms. And the response generally is maintained over 6 months, which was very good, not very much drift back after going through these therapies. And without an increase in suicidality. We had very few exclusion criteria, made everybody really nervous that people were going to start talking about their trauma and then want to, you know, maybe think about taking their own life. Not true at all. You know, knock on wood, we have not had a completed suicide from somebody in treatment to date. We do a lot of risk management, a lot of screening. We manage people outside of hospitalization with this. I mean, I'm calling all of these JACO near misses, because people who come into your clinic and say, I feel horrible, I think I'm going to go home and take pills, I think I'm going to go and drive off a cliff, then okay, come on, let's get it figured out. Let's talk about it. They trust our therapists so much to be able to present for that. It just makes me really, really proud to be part of this group that they would do it. Spouses will bring in a service member and say, I don't know what's going on with him, but it's different, and I could only get him here to see you. You know, can you help him out? Now, you know, I'll say some people needed hospitalization, absolutely. But we had another study we finished up at Fort Carson, actually with General Keenan, she was there, and we tested a way to keep people out of the hospital who came in with suicidality, and it saves the military millions of dollars in inpatient expenses, and, you know, gives people control back of their life. So anyway, we really think that was a, you know, major finding. We had a better number for, you know, how many near misses, but it probably, at least once a month, we'll get a call about, somebody who feels really bad. So there's a number of next steps, maybe 10 to 12 sessions over 6 to 10 weeks isn't enough. Maybe combat-related PTSD, you got to address a couple different traumas. Maybe you just need 1 or 2 more sessions and you could have a breakthrough to do it. So maybe everybody gets 10 to 12 sessions isn't enough. There's multiple traumas that may need to be addressed. If somebody's sexually assaulted, you can pinpoint that one event and go over it. In combat, as you all know, there's, convoys, there's mortar attacks, there's mass cows, there's, animals, there's children, there's all kinds of trauma, and maybe just focusing on one of those traumas isn't enough. Maybe, you need to work through a couple of those to, try and make sense of it. And then we need to tailor treatment in consideration of comorbidities. There's a lot of head injury and, more importantly, a lot of post-concussive symptoms. And if people are having trouble focusing, mentating, they've got this headache that's driving them crazy, you can't really think about undergoing treatment. So trying to think about how to address that. And a lot of hazardous drinking out there. We didn't have a lot of people that met the audit, alcohol use and disorder, whatever, criteria for alcohol use disorder, but they do a lot of binge drinking on the weekends, a lot of binge drinking. And so how does that affect going into treatment and thinking about it? We'd like to think about tailoring treatment for the type of trauma, for moral injury in particular. If you viewed something that you feel is morally injurious, that is, how do you make sense of that? It's never going to be right. Killing a kid is never going to be right, no matter how many times you think about it. So how do you make sense of that kind of stuff? And then the value of a stepped model of care. So I do want to talk about some of the other studies, but I just want to take a minute to talk about the value of stepped care. And this was the study I got funded to do, testing the role of exercise in the treatment of post-traumatic stress symptoms. So my program of research while I was on active duty was testing exercise interventions in people with cancer and recovering from cancer, and was just a complete zealot for that. So I joined this group, and it's like, okay, I don't really want to give that up. What am I going to do with this? And Alan Peterson, who's a long-distance runner, knew of my interest, and he said, this prolonged exposure stuff, the thing I just told you about where you keep retelling your story, people get really emotionally worked up. I think if they were exercising when they were telling that tale, that would help them process it better. Like how many of us get stressed out and have to go out for a run or need to go for a walk or go climb stairs? It's like a stress release for doing that. So he said, I think we ought to test that. So I'm like, great idea. So the Tri-Service Nursing Research Program funded it, which I was very much appreciative, and we did a randomized controlled clinical trial here in San Antonio and up at Fort Hood. Almost right after we started it, an editor from Runner's World came out. This article, Running Back from Hell, was published in March of 2014 and then was republished in June 2016 for their 50th anniversary as one of the 50 top articles that Runner's World had ever published. So they came out to Texas. There's some people up at UT Austin doing some work, interviewed us. We took the editor up to Fort Hood so she could meet with service members, see what physical therapy or PT, AFPTs were like up there. So it was great fun. And I tell you, I look like 50 pounds heavier in the picture in there. I'm so irritated by that. It's like, oh, lovely. Here's an article on running, and my blouse, it was like all puffy. So anyway, I do run, really. I do exercise. It's like, yeah. Anyway, okay. So these intervention groups that we tested, it was a basic 2x2 design. I wanted to test exposure therapy, yes, no, exercise, yes, no. So one group, there was 4 groups, one group had aerobic exercise only. We wanted people to exercise 5 days a week for 8 weeks. It was just what the American College of Sports Medicine recommends. Moderate intensity, you don't have to do it as long, higher intensity, 3 days a week, but we wanted people to aim for 5 days a week. Second group got 5 in-session imaginal exercises with a trained therapist over 8 weeks, so 5 sessions over 8 weeks. the combined group, they met with a therapist, but then that tape that they made that they're supposed to listen to every night as part of their homework, when they listened to that tape, we wanted them to be exercising. So they could run, they could get on the treadmill. We wanted their heart rate to get up to 60% of their heart rate reserve. And you know, you can get on a treadmill and crank that incline up, and you can increase your heart rate. So, but we wanted them to be listening to their therapy tape. And then the negative control we were having some trouble with, until I have to hand it to our biostatistician. He's like, well, Stacey, you're a nurse. Don't you guys do self-care type things? So it really got me thinking, and yes, as nurses, we throw a lot of paper at people. Go check this website, go check that website, you know, there, you're off. I'm on to the next thing. And I thought, I think we could do better with that. So what we did was pull the National Center for PTSD. This was returning from the war zone. We pulled that off the VA website. We felt that it had kind of a nice overview of self-care after you've been exposed to trauma and things that you might want to do. But we wanted to control for interaction with a professional. So what we did is have these people come in 5 times to meet with a nurse. Now, we had to work overtime because the nurses were ready to solve all the problems. Okay, you need to join a gym, and this is the gym areas down there, and oh, you want to go to church? Okay, well, the Catholic ones here, Protestant ones, you know, they wanted to like solve all the problems for them. And I'm like, no, we're not solving problems. This is a nurse-led self-care intervention. So the discussions went more like, you know, here's a list of things people do that makes them feel better. Have you ever tried any of those? Yes, no. Has it worked? Not very well. Okay, well, is there anything else on here you might be thinking about trying? And I tell you, I don't have a slide. I need to put one together. The number of things that people came up with, like they said, I'm going to take my wife out to dinner. I'm like, wow, now that's really good self-care. You know, I could start exercising. They could decide they wanted to go to a therapist. They could rejoin their church and church groups. So there was a lot of different things. The nurse was not to solve the problem, just facilitate the discussion and then check back in with them. So these are the findings. So good and bad, all the lines are going down. These are PTSD symptoms. The yellow group did not go down as far, but it did go down. The yellow group was a nurse-led self-care intervention part of it. So good or bad, it worked. I mean, people had less symptoms even when they met with the nurse to discuss, you know, potential self-care. Bad news is if you're designing a research study, you want one of those lines to be straight, because otherwise you don't have a comparison group. So, and you want to try and recruit all your subjects, which we were not able to do. You know, none of the things we were testing was an evidence-based therapy. It was pieces of an evidence-based therapy. So we really wanted people that were having PTSD symptoms, but not full-blown PTSD. Well, those people don't come in for care. It is if they come in, our first 13 people we screened, only 3 qualified. The other 10 had to go on to other Strong Star studies because they met diagnostic criteria for PTSD. So this was like really messing me over until I started hearing about the screening we were doing up at Fort Hood. And I'm like, wait a minute, we're turning 20% of the people who come in for care away because they don't meet PTSD criteria? Let's open the study at Fort Hood, and instead of saying, hey, sorry, you feel bad, you thought you had PTSD, you don't have PTSD, don't let the door hit you on the way out, we could say, hey, you didn't meet the criteria for this study, but we know you're having symptoms. We've got this exercise study. Would you be willing to at least hear about it? Oh, night and day difference. You know, yeah, people, if they're so bad they want to come in for care, they're willing to stick with you around this. So that was good. But, you know, we still didn't meet all the enrollment criteria. But the intraocular test, like looking at graphs, it pretty much hits you in the eye that something went on. And a 10-point change in the PCL score with only meeting 5 sessions is clinically significant. So the challenges, we had service members with symptoms don't seek care. We didn't meet the enrollment goals, resulting in a lack of power to detect significant differences between the groups. In the nurse-led self-care group, it wasn't the best comparison, but we weren't going to bring people in and not do some sort of treatment with them. And I will say, after people finished our study, if they still met criteria or were still experiencing symptoms, we would then refer them on to other studies or other avenues for care. So the idea was to get everybody some treatment to hopefully relieve their symptoms. Whoa, that writing got really small. So the conclusions, the planned statistical analyses were not significant, but clinical improvements were observed in each of the 4 groups. And then this limited, remember, only 5 meetings with a therapist could build trust with patients, that then they might be more willing to go on for more care or more specialized care. And then, it really pointed out the need for ongoing reassessment and referral. And I think that's where the nurse can really play a role. Self-care interventions work well for a bunch of people. A nurse can augment those. But then the nurse can also identify what's working, what's not working, help build trust to then pass it off to normally a psychologist or a social worker to engage in the evidence-based therapies. So going back to Strong Star, Gen 2, like what are the next generation studies that we're using to try to improve this response to PTSD? We just completed a variable length cognitive processing therapy where people were treated until they remitted from their symptoms. It could be as few as 4 sessions, and it could be as many as, we took them up to 22 sessions. After 22 sessions, we kind of called it quits at that and said, okay, we got to figure out something else is going on. We don't have the people are still in follow-up, so we haven't analyzed that data yet, but that was one approach to maybe people only need a little bit more treatment, or maybe people can get done sooner and get through the system. We also have a ketamine study going in San Antonio for antidepressant-resistant PTSD. Fascinating. So ketamine has been effective for the treatment of depression. It's the miracle drug these days. You see a lot of ketamine. We've got ketamine clinics right here in San Antonio. Has not been systematically tested in post-traumatic stress disorder. We're comparing 2 different doses of ketamine to a placebo control and giving it repeatedly, not just 1 infusion. We do 8 infusions over 4 weeks and then follow people up for a week. We lost our nurse right as we were getting ready to start that study, and I'm like, I'm a nurse. I used to take care of patients. I was a cancer nurse. I even started kind of hard IVs. So I filled in for a while, and I'm still kind of their backup nurse when we've got a lot of patients and we're kind of low on staffing. And it is so much fun to treat patients, to engage them, to work with them. Just great bunch of people that are in need of care. But just like the antidepressants, we don't think ketamine is going to be the cure for everybody. We think that maybe we can get control over symptoms, and then they can engage in some of the behavioral therapies that are going to affect the long-term remission and cure. Project Remission is a 3-week program where we bring people in every day, have done a lot of augmentations to address the weaknesses of addressing multiple traumas. We don't let them leave the office and say, oh yeah, I'm going to do my homework. Oh yeah, I'm going to do that. No, we're like, why don't you go sit in that office right over there and listen to your tapes and really, get at and clean out that wound and then get some healing started. So that study's testing that. We've got a web prolonged exposure treatment modality we're testing, and then we're testing a writing exposure therapy versus cognitive processing therapy, and that study is still enrolling also. So just trying to come up with where can we go with this. So back to your tax dollars at work, what we feel some of the contributions of the Strong Star Research Consortium have been. We've assessed and treated over 6,000 active duty military. Now, some of this was the pre-deployment, post-deployment study. Of course, not everybody needs care, but getting an assessment and then getting people referred has been very advantageous, we think, for the service members as well as for the studies. We've provided over 25,000 hours of clinical care that the military did not need to provide or did not need to send out on the healthcare market to TRICARE, save literally millions of dollars. An inpatient stay up at Laurel Ridge, that's our inpatient psychiatric hospital here in San Antonio, is it's $1,000 a day. And they do give good treatment up there. They give evidence-based treatments, but it's a minimum 30-day hospitalization. They have a dedicated military unit. They have like somewhere between 30 and 50 service members that are on there all the time. It is a huge cash cow for Laurel Ridge up there. And not that they're not doing care, but we feel like we're trying to test ways to deliver that care and save some of that money, use the research dollars to save some of that clinical care. Had over 50 peer-reviewed publications in high-impact journals. We had a JAMA article last year, which is very exciting. Substantial impact on the military health and readiness, and we're really hoping to address the science of combat-related PTSD. It's not the same as civilian trauma. There are similarities, but how do we get after the military unique combat-related aspects of this? In addition to the research, we also have a number of clinical resources. These were implementing therapy, cognitive processing therapy, prolonged exposure to active duty military, special considerations, case examples, trying to help therapists get after strategies to talk with service members. So we have that going on. The Bob Woodruff Foundation and the Texas Veteran and Family Group funded a Strong Start training initiative. TRICARE and lots of insurance companies, they're treating service members or veterans in the community, but they don't know how to. And so a lot of money is going out, but you don't even know what the outcomes are. So we have 2 of our expert clinicians got funded to training programs across the country as well as here in Texas, bring in civilian providers who want to give better care. They just don't know what's a fob and what's the wire and, you know, how could you possibly have seen all this stuff? Yeah, you possibly could. So how do you begin to address those has been really very rewarding and successful. And then we have a dissemination conference. It's actually going to be here in San Antonio in a couple weeks to bring in our investigators. We have too many. We have 500 registrants, and the fire marshal says we can have 450. So we're going to figure that out, but that's here in San Antonio. So just like if you've ever heard of the San Antonio Breast Cancer Conference, we would like to be the go-to place for the San Antonio Combat PTSD Conference and help disseminate some of these findings that not only we, but investigators across the country are doing. Really looking for partnership in team science, and aren't nurses all about teams and team science, and really trying to combine, augment the research, the clinical care, and the education and training, because they each support each other and then, you know, advance each other accordingly. We have a website. Who doesn't have a website these days, right? But anyway, if you ever have a chance, you just Google Strong Star. Our publications are there. The studies that we're enrolling, you see the Get Treatment in the upper right-hand corner. If you or you know anybody who needs treatment, we've got studies for service members. We've got studies for active duty. Up at Fort Hood, we've got studies at West Haven, across the country. We've got a pretty good network, you know, want to get people the highest quality care and get them back to their lives and enjoying their lives.
Okay. It's a long way to go. As you can tell, this is a terrific topic. And you can see why we brought Stacey in. You know, Stacey was a big encouragement to me when I was doing my dissertation. She was a champion for me. But her level of professionalism and expertise is incredible. And so we're really thrilled to have you present this topic here that's so relevant. And so we want to give you the mandatory nursing thank you gift in the little bag.